Hello, students. Welcome to the first of a series of podcasts done by yours truly on diabetes. So, first, we'll just start off with what is diabetes? Diabetes is really caused by a lack of insulin, as we talked about before. It's really the insulin deficiency, or even a deficiency. It could be insufficient production of insulin, such as with type 1 diabetes, or production of defective insulin, such as type 2 diabetics just don't make the right amount or proper amount of insulin, or the inability to use insulin, again, which is a hallmark of type 2 diabetes, that the insulin just can't get inside the cell. They make insulin, but it just can't get inside the cell, either due to the lack of insulin in itself being the locking key for glucose to enter the cell, or due to the condition called insulin resistance. As I said earlier, glucose cannot enter a cell without insulin, so this lack of insulin leads to elevated serum levels of blood glucose levels. The definition of that is hyperglycemia. And insulin, of course, is produced by a hormone, is a hormone produced by beta cells in the pancreas. So as I said, insulin is like a key to get the glucose inside the cell. When you have insulin deficiency, the cells are hungry. They're going to look for other sources of glucose when glucose itself without insulin cannot enter the cell. The main thing that insulin does is that it releases sugar and increases the passage of glucose into the cell. To ensure glucose uptake, insulin actually packages everything else up. So fats are stored as adipose tissue, and proteins are stored as muscle. This is known as pro-insulin effects, what insulin normally does. Now, with a lack of insulin, such as with type 1 or type 2, glucose cannot get into the cell. So the cells are hungry. So glucagon is released, and there is not enough insulin. When there is not enough insulin, and since diabetics don't have insulin, insulin is necessary to turn off glucagon. Glucagon continues to outpour, and you have hyperglycemia. In the face of hyperglycemia, proteins break down to amino acids. Fats are broken down with the release of triglycerides, fatty acids, and ketones. So a type 1 diabetic is really someone who's insulin dependent. They are always going to be insulin dependent because oftentimes more than 75% of their beta cells have actually been destroyed in the pancreas at the initial presentation, which is usually in DKA in the emergency room. Usually strikes younger clients, although now up to about the age of 25. As I said, it's an acute onset. Usually it follows some sort of a flu or a viral episode, and then the child is usually brought into the emergency room and they're diagnosed with type 1 insulin dependency. The basketball player Ray Allen's son just recently succumbed to this. There's usually some sort of genetic predisposition, but just because your father was diabetic doesn't necessarily mean you'll become diabetic, but there is a genetic predisposition. And typically these patients are very thin and lanky because of their decreased protein mass as a result of muscle wasting and decreased adipose tissue stores, which have been utilized during the course of their hyperglycemia. And then you have type 2 non-insulin dependent diabetics. Typically non-insulin dependent, but they can become insulin dependent when all else fails, such as the oral medications, which we'll cover in a subsequent podcast. This usually affects older clients, usually greater than the ages of 40, although you have to remember that teenagers nowadays with obesity are becoming more and more higher risk with obesity of becoming diabetic. So you have to remember that this number actually should be is actually coming down as more and more teens are overweight which those numbers are getting better, by the way. I'm happy to report. A lot of the efforts through Rachel Ray and Michelle Obama have actually been decreasing some of these numbers that's in teenagers and obesity. So it's important to know that this isn't always greater than 40. It is, however, a slower and insidious onset as opposed to diabetic ketoacidosis, which is much more acute. And the risk factors are obesity. I've got your little couch potato there. Um, and the central distribution of fat, which can sometimes be genetic um, or ethnic, as in the Pima Indians. So the central distribution of fat is usually causes the increase in the waist-hip ratio, which leads to the diagnosis of diabetes. And then it's always related, usually typically related with decreased physical activity and the diet. It may be a high sucrose, high fat, low fiber diet, which is typical of our Western diet where everyone eats fast foods on the fly and there's no fiber and high carbohydrate intake. So as I said earlier here, there's the waist circumference, waist hip ratio is elevated. The term diabetes refers to the obesity that caused the diabetes. The main therapy for these patients, lifestyle modification, is weight loss. Try to get them an initial loss of 5 to 10% of their body weight, and then you may actually decrease the risk of them becoming diabetic or staying diabetic by as much as 50%. So it's really important. Preventatively, we know that exercise on a regular basis can prevent diabetes in 50% of the population, and walking is actually one of those keys to that high level of prevention in diabetes. So weight loss after diabetes is also important, and that's why we talked a little bit about bariatric surgery and some of the criteria that might be that are being found that diabetics who have undergo bariatric surgery due to the weight loss actually do reverse their diabetes. So what is the diagnosis of diabetes? Diabetes is diagnosed. I actually like to think of number one first because it's really the easiest one. Fasting plasma glucose greater than 126. Fasting means that you've not had anything to eat for more than 8 hours. And that is the Joslin Clinic's, the American Dietetic Association, Diabetic Association's number, and pretty much generally regarded by everyone, including your textbook. Number two happens every other day. For instance, when patients go into the hospital and they just get a random blood sugar drawn and it's greater than 200, well, that means it should never really be greater than 200 unless you have an insulin deficiency. So that's one way we sort of capture patients. And then we do a fasting to see if indeed we're right or were they just under an incredible amount of stress at the time, etc. And you can also verify it by doing this lastly, the 2-hour postprandial glucose, where we check to see if it's actually greater than 200. This is relatively not done very often. Maybe some pregnant patients may have this done. But as I said, no one after 2 hours after a meal should still have a blood sugar of greater than 200 unless they have insulin deficiency. So that's the end of this small podcast on what is diabetes. Look for the second series is what the heck is diabetic ketoacidosis. I hope you enjoyed this podcast. Stay tuned.